Hello, friends. It gives me great pleasure to speak to you on IACMCON. I hope going forward, we can meet each other at meetings once COVID finishes and we are in the post-COVID era. My heartfelt congratulations and thanks to Dr. Mukut Rai and Dr. Dipankar Prakash Bhomik for having invited me to speak at this meeting. We spoke about COVID and post-COVID, and my topic, interestingly today, is about post-COVID fibrosis. So in the next 25 odd minutes, I'm going to talk about various facets of post-COVID fibrosis. Evidence in this area is lacking. Hence, a lot of what I'm going to say is based on hypothesis, it's based on review papers, and a lot of it is related to my thought process about post-COVID fibrosis. We are also in the middle of accumulating Indian data through the Indian Chest Society, and hopefully we will have more evidence-based data going forward, and maybe 6 months down the line, I'm speaking to you guys again, there'll be more of evidence. So again, my thinking, and a lot of this is also borrowed from my good friend, I'm a fan of Professor Athol Wells. So a lot of this is also his thinking and my thinking amalgamated together about post-COVID fibrosis. So when we talk about COVID pathways and pulmonary fibrosis, you can think about lung fibrosis in two broad categories. There could be the virus causing direct damage to the lung tissue and hence resulting in acute lung injury, which results in healing by fibrosis. It would also be that there's immune dysregulation. The body's immune system directs itself against its own organs, the lung in this case, and this immune dysregulation is triggered by the virus, which results in fibrosis. Now, when I do this talk today, I'm going to talk about the disease in these two different compartments. However, I do that for your understanding and for my understanding, because a lot of what happens in the lung in real life scenario is probably an overlap of these two factors. Hence, the direct damage by the virus and the immune dysregulation happen in various percentages in different people. Maybe there's an upper hand of one mechanism as compared to another in different cases. What's the basis of saying this? So there have been some small autopsy studies in COVID. And in COVID, the most characteristic lesion that we see is acute lung injury. It looks like an ARDS lesion on autopsy studies when we look at the lung under the microscope. Along with this, however, there is also microvascular injury, the very small microthrombi or macrothrombi, which seems to be present in most people who've ended up with acute lung injury or ARDS. Hence, the procoagulant pathway, the hyperthrombotic pathway, and the pathway which results in cytokine dysregulation seem to happen together. There's also disproportionate fibrosis, the lungs affected by acute lung injury heal by fibrosis, and there's disproportionate fibrosis, prominent fibroblastic foci, and severe fibrotic change, all of them in the lung. The pattern in the lung more looks like organizing pneumonia, and hence the interstitial lung disease pattern that we talk about in a lot of cases is actually the organizing pneumonia pathway. Hence, my summary of the literature, the limited literature that is available, is that the viruses trigger an autoimmunity, and that's documented in small studies, but robust studies looking at lung histology, most of which is autopsy-based studies. The viruses can trigger an ARDS. This is true even in the previous coronaviruses. So if you think about the MERS, if you think about the SARS pandemic, that's what happened even in those pandemic. The fact that the virus triggers an ARDS-like reaction, as we said, is hence well recognized. What's unique about this disease is that both these pathways, the direct viral triggering autoimmunity and the virus triggering ARDS, seem to go hand in hand and are complementary to each other, which is why there seems to be so much damage to the lung. Hence, COVID can trigger major immune dysregulation without necessarily causing severe acute lung injury, at least in some individuals. Let's do a case, and we'll do a couple of cases. This is the first of them. A classic case, a case that you would have seen if you have treated COVID. 56-year-old man with mild symptoms, the mild symptoms being fatigue, loss of smell and taste, which seems to be very common in this disease. There was sore throat, there was a dry, irritant cough. And based on this, COVID test was done, the RT-PCR test was done, and it came back as being positive. There wasn't much of dyspnea, there wasn't much of cough. However, the symptoms resolved over a period of 10 to 14 days. However, 5 to 7 days later, the dyspnea started again and gradually increased over the next 4 weeks. The autoimmune screen in this individual was negative, and you can see the scan in front of you. And if you look at my cursor, trying to point out areas of scarring, these areas of linear atelectasis-like changes, these areas of organizing pneumonia that you see seem to be very classic in the COVID patients. Based on this, the patient was started on prednisolone 40 milligram. There was gradual tapering of the dose. There was rapid symptomatic relief initially. The CT, I've shown you just one cut, but the CT, when you look through it, showed volume loss more prominent in the lower lobes. And there was a possibility of traction bronchiectasis. I'm trying to point my cursor to the areas of traction bronchiectasis, which seem to be appearing here. So that's the baseline, that's the case. And we talk about post-COVID autoimmunity. So we said that post-COVID autoimmunity is a reality. What we are doing here is to extrapolate evidence from other conditions. And the various mechanisms it seems to trigger is an SLE-like phenomenon with vasculitis. Some patients seem to have vasculitis resulting in Guillain-Barré syndrome. Some patients will have APLA positive. These are the patients who often end up with a stroke or an MI or a general coagulopathic state. A lot of people would have lupus anticoagulant positive, and this is from a New England Journal study, so robust study, and a couple of cases which are anti-synthetase positive. So that's all the evidence we have that post-COVID, this triggering of the autoimmune mechanism. So the autoimmune pathway, in some cases, a very small percentage, thankfully, results in fatal fibrosis. The question that arises is, these patients who were apparently normal before having COVID, did they actually have a baseline fibrosis on top of which this patient have had more fibrosis? So these patients might have been asymptomatic. These patients might have interstitial looking changes on the lung, the so-called ILAs. And on top of that, they've had COVID fibrosis. These patients, if they happen, are probably going to have a worse prognosis as compared to people who've had a pristine lung, a normal lung before. So carry home message, if patients have background fibrosis, even they're asymptomatic with it, if they develop post-COVID fibrosis, the outcome in these patients, the prognosis in these patients is going to be more worse. So what are the key unsolved questions? So that's the question that I ask myself. I'm not asking you these questions, but we don't have evidence for these. How exactly do autoimmune pathways fit into the pathogenesis of the patients who have the severest of infections or the fatal COVID disease? What are the key triggers which amplify the cascade and have caused a lot of morbidity and mortality in certain patients, but not in others? And then this Poletti study, the guru of cryobiopsies, who with 25 biopsies said that there are equal numbers of equal and late disease when he's done biopsies. So who gets the fibrosis, who doesn't, who gets the aggressive fibrosis, progressive fibrosis, the PF-ILD pattern is not something that we can predict till date. There's some data that was given to me by Professor Athol Wells, which I present on that particular slide. So in early disease, the patients will have neovascularization. So new vessels grow into the lung. There is a lymphocytic inflammation, lots of lymphocyte coming into the lung, and they're confined to the covering, the epithelium of the lung. This finding, if you find it in biopsy, means that there is an autoimmune phenomenon, an auto-inflammatory phenomenon that might happen. And this might be the time when you need to start doing something, when you start the steroids in these patients at this stage. Unfortunately, you cannot diagnose that without a biopsy, but slightly early start of steroids seems to prevent this. So in fatal cases, fibrosis is prominent. Can we, with imaging, when we start finding interstitial changes, start the steroid at that point of time? And that's what the researchers are showing. Earlier start of steroids seems to be the way forward. So we need a prognostic algorithm, which is centered on parenchymal disease, not different to what you would get in patients with other interstitial lung diseases. And maybe the PF-ILD pattern would be the algorithm that you would use. So this again is from the Brompton group, Professor Devraj, and thanks to him for sharing this slide. You would have seen CTs like this before. This is the COVID ARDS. You can see the architectural distortion. You can see the areas of scarring and fibrosis, which are mainly subpleural. And this is during the acute hospitalization procedure. And many would look at this fibrosis early on in the disease process and think of starting the anti-fibrotic at this stage, especially in the high-risk patient who is elderly, who has got multiple comorbidities, or who's got an established cytokine storm. That may be the time to start the anti-fibrotic. This is a study which looks at chest X-ray scoring and HRCT scoring. And you can see the greater the chest X-ray score, greater the HRCT score, greater the mortality. Hence, the chest X-ray and the CT have prognostic value along with the other prognostic markers that we always speak about. So post-COVID ILD, I show you one example from our cases. This is a patient who was in intensive care at Fortis, where I used to work till recently. And you can see the changes on CT. Lots of organizing pneumonia, areas of scarring, linear fibrosis, which is mainly in the subpleural areas. And then 3 months down the line, you can see that a lot of the ground glass and the consolidation is gone. And you can see on my cursor, the areas of linear atelectasis and some ground glass opacities being left behind. This is another patient who's got acute COVID ARDS. This patient required a lot of oxygen, required non-invasive ventilation, required HFNO. And you can see the basal changes are profound. The reason I put up this slide is that with time, 3 months down the line, most of the ground glass seems to have gone. And this is a recurring pattern we see a lot of these patients. And this patient happened to be on steroids. Whether steroid helps in the reversal or whether the reversal happens by itself is again an unanswered question that we haven't managed. Let's look at another quick case. 52-year-old man now with severe COVID in intensive care, prolonged hypoxia, was on non-invasive ventilation. Obesity with a BMI of 35 was his only comorbidities. 2 weeks recovery prior to hospital discharge, and then ongoing severe hypoxia and dyspnea. And he was referred to me 2 months after discharge with what was termed as post-COVID ILD. You can see the basal changes on the chest X-ray. The left side looks very much like COVID on the chest X-ray, and on the CT again, you see this pattern, which is basal and subpleural. And my cursor shows you areas of traction bronchiectasis. So you can see the areas of traction bronchiectasis on there. So baseline CT, and you can see established fibrosis on the 3-month scan there. There is no honeycombing, but there's definite traction bronchiectasis, which I feel signals the presence of fibrosis. The patient was re-evaluated again at 5 months. So the previous CT was at 3 months. This is at 5 months. And you can see while the CT is better, the changes are less than before. There's still some amount of traction bronchiectasis in these individuals. So there is clinical improvement over 3 to 5 months. This patient was an anti-fibrotic at the time, and I'll come to drugs when I discuss my last slide in a bit. But this patient was an anti-fibrotic. The patient had steroid for 2 months and had response. Whether the response was to the drug or a natural healing process is something that we do not know. So we've been there before. We've been there before during the SARS pandemic, during the H1N1 pandemic, during the MERS pandemic. And this is looking at CT imaging of ARDS and ECMO. So this is looking at histology and radiology correlation. So I want you to see the organizing pneumonia and fibrosis. Look at my cursor on there. So this is organization and fibrosis as a result of acute lung injury. I'm sorry, the slides change on their own, but this is the areas of fibrosis and acute lung injury. And then the CT correspondingly, you see organizing pneumonia. And then you see the fibrinous stage when the lungs become more solid. There's areas of traction bronchiectasis. And then later on, the organizing pneumonia goes and there's a little bit of scarring left behind. And then you see airway dilatation. So you see the airway dilatation on there. This is a signal that there is some amount of fibrosis. The bronchus becomes tortuous, the main bronchus, the segmental bronchus becomes visible till the very periphery of the lung. And this is imaging in ARDS. So ARDS survivors, and residual abnormality at 1 year is present in a minority of cases, and in a lot of cases is due to the presence of positive pressure. So while COVID causes some degree of fibrosis, the giving of HFNO, the giving of non-invasive ventilation, the giving of invasive mechanical ventilation all result in a degree of fibrosis in these patients. Hence, it's COVID plus the fibrosis caused by the positive pressure with gadgets that we have talked about. So there's key difference between COVID lung damage and classical ARDS. And one of the important things is the so-called organizing pneumonia that we seem to find so commonly in patients with COVID-19. So this is, again, autopsy studies from very recently. This is a study that I've quoted from about a month ago, which again came out in the New England Journal, autopsy study, which shows organizing pneumonia on histology in autopsy studies. This comes forth as being subacute injury. However, in isolation, just having organizing pneumonia does not predict prognosis. In the cryobiopsy studies from Poletti, classic organizing pneumonia, the one we defined in interstitial lung disease, was lacking. There was a lot of lymphocytes, but the foreign body cells you find in organizing pneumonia seem to be absent. And hence, I feel that the terminology of organizing pneumonia for all the scarring that we see in patients with interstitial lung disease might be responsible for post-COVID ILD getting such a widespread publicity as it has today. So putting this all together, and I'll spend a couple of minutes on this slide because I'll also talk about drugs. COVID lung injury differs from classic ARDS, but slow resolution pattern might be similar to what we get in ARDS. Ventilators-induced lung injury, the so-called VILI, if added to COVID, would add to the post-COVID fibrosis, and these are the patients who seem to have critical illness, severe illness, with more of morbidity and mortality. 96% of discharge from hospital are patients who are not dying from a mechanical ventilator and are ECMO. So ECMO seems to help. And if you manage to start ECMO early in patients who require mechanical ventilation, looking at all comorbidities, the prognosis seems to be more favorable. And the only studies we have with cryobiopsies, the Poletti studies, 2 patients had features of ARDS, and these were the only 2 patients who underwent mechanical ventilation. So what I'm trying to get to there is that if you get classic ARDS on a CT, the chances that the patient will survive is going to be lower as compared to patients who do not have ARDS. So I'll talk without slides, a couple of minutes, about drugs. So the drugs are anti-fibrotics, and the drug is steroid. The steroid would be in patients who have a lot of GGOs, who have an organizing pneumonia mimicking pattern on CT, and the steroid would be a tapering dose over a period of 1 month to 3 months, depending on the severity and the response to steroid therapy. The other drug is going to be anti-fibrotics. And the anti-fibrotics we're talking about here is in the order of pirfenidone later and nintedanib earlier. So nintedanib seems to have more evidence, pirfenidone seems to have lesser. Nintedanib also has more evidence in that it seems to act against the IL-1 and the IL-6 and might have an added effect against the cytokine storm, and there might be some rationale in starting the nintedanib early. The dose, as you all know, is 150 milligram twice a day. I didn't talk about the dose of steroids, but you would want to give the 0.5 milligram per kg body weight to start with, and no more than 40 milligram a day. That would be my take on steroids. So a relatively lower dose of steroids is what you are looking at. So those are my concluding remarks about post-COVID ILD. Important to find out whether having pre-existing interstitial changes on a CT add to a poor prognosis, and my understanding is that it does. If there's pre-existing autoimmune pathway, so if someone has Crohn's disease, for instance, or has rheumatoid arthritis, or has SLE, any of the autoimmune diseases, then COVID-induced flare-up, the cytokine storm, the lung damage, the ARDS is going to be greater. And that's because COVID seems to be triggering the autoimmune pathway. The residual fibrosis that remains depends on the severity of COVID-induced damage and also the use of positive pressure in these patients. The positive pressure adds to the COVID-induced lung damage in the severest of patients of COVID. The resolution happens, the CTs get better, even when there's fibrosis established in the way of traction fibrosis, but like ARDS, the time taken is a long time. And whether COVID triggers progressive fibrotic lung disease, so CT scan gradually getting worse over a period of time in a small minority of people seems to happen, but who it happens to, how you would predict prognosis is something that we still don't know about. And lastly, like I said, 3 to 6 months down the line, when we have data from the Indian registry, maybe we'll do another talk, maybe we'll have another chat, and hopefully I will have more answers than the number of questions that I have posed today. I hope you enjoyed that talk, and I would be very happy to take questions. Thank you very much. Thank you for listening.